Hello again. My name is Dr. Betty Dube, and I will be covering obesity in this short lecture. Here's the captioning statement. If you're going to use the captioning, just remember they're up to 90% accurate. Take a moment to read the statement. So first I'll just want to go through the common myths when it comes to obesity. So some people think it's a modern fad, if you like, but it's not. It's been here for many years and has improved or not improved due to accessibility to food, healthier food. Again, it's not a lifestyle choice or lack of willpower. It is quite complex, involving genetic, biological, environmental, hormonal, mental health, and socioeconomic drivers. So it's not just down to poor choices, and one does not grow out of it, as stated here. But importantly for us as healthcare professionals and pharmacy professionals, not only does it's just not a large weight loss that provides health benefits. Even as little as 5% of the weight loss does significantly improve the health markers like blood pressure and blood glucose for somebody living with obesity. Again, all these here are just myths for us to be aware of, and the links that people have been just are thinking are facts, but they're not. And certainly there is a genetic aspect to it. Again, pause this recording to have a quick read of these. So overweight is a condition of excessive fat deposit, but obesity itself is classified as a chronic relapsing disease arising from complex interactions between genetics, neurobiology, eating disorders, access to healthy diet, market forces, and the broader environment. So the World Health Organization defines obesity as one having a body mass index of 30 or over, and this is BMI calculated using one's weight in kilograms divided by their height in meters squared. Again, this particular parameter is not the most accurate one. For example, if somebody has a higher weight due to muscle building, for example, and then they're short or they're not as tall as the BMI calculator would want it to be, then their BMI can also be very high, but when you see them, you'd see that it's not a fat weight, it's muscle. So just be mindful when you interpret in the BMI results. You still have to look at the person. So again, obesity is a chronic, relapsing, multifactorial disease or condition involving abnormal excessive fat accumulation, and it's been associated with these increased morbidity as well as reduced quality of life. So being a chronic condition, it does require lifelong management. Also, its prevention and early intervention does help it progress into the comorbidities listed here. So the World Obesity Federation is also defining it as a medical condition described as an excessive body weight in the form of fat. So important here is the excess body weight is in the form of fat. And this is accumulated and leads to severe health impairment. So it is a complex with many factors, including activity levels, diet, one's genetics, other diseases, conditions, mental health as well, weight, stigma, poverty, and even one's environment. So in most cases, it will be a combination of many of these factors, and it's not simply driven by eating too much or not exercising enough. So we have to be mindful each time we have a look or think about obesity as a medical condition. So the diagnosis of it, again, I did mention, is the body mass index, and this is what's categorized historically as a healthy weight, overweight, obesity, and severe obesity. But again, remember, it's the excess fat weight. So BMI is a very crude measure and is not used on its own to diagnose obesity. Okay, other factors such as gender, ethnicity, body composition, age should be taken into account. As well, other measures that can be used include waist circumference, okay, as well as the risk of developing other health conditions such as type 2 diabetes. So in the last few decades, obesity has expanded globally as countries have experienced greater food security or insecurity, socioeconomic development, shifts in diet, physical activity, and societal and individual behavior driven by globalization and industrialized food systems. So these forces have created increasingly obesogenic environments, contributing to what is now a global public health crisis with more than 1 billion people living with obesity and prevalence rising nearly in every country. And these are just statistics from the World Health Organization. So according to some 2022 statistics, 1 in 8 people are living with obesity worldwide, and just have a look at those numbers there. And then also children are affected. Okay. So let's move on. In the UK, obesity is prevalent just like the rest of the world, and these higher rates are noticed in deprived communities, certain ethnic minority groups, as well as people with disability. And interventions must be equity driven, culturally sensitive, and best suited for the target. Okay. So what is the best way to lose weight, you wonder? So there's no one best way to lose weight. Personal circumstances must be considered when making recommendations. Diet improvement and increasing activity are key factors of losing weight, but they're not the only ones that need to be considered. When aiming to lose weight, it's important to have realistic goals and that are achievable for that person. And this success in weight loss does boost somebody's ability to lose weight as well. And remember, weight loss of just between 0.5 to 1 kilogram a week is a safe and realistic target. So there is no one fix, and that's always something to remember. The Total NICE has classified the levels of weight management, and these are into different tiers. So there's tier 1 that covers universal services such as health promotion, public health services, and primary care. And then there's tier 2, which covers lifestyle interventions such as commercial weight loss programs or seeing your GP or nurse for advice. And then there's tier 3 that covers specialist weight management services for those that need more specialist support. And then there's tier 4 that covers weight loss, such as bariatric surgery. Okay. So when it comes to pharmacotherapy, I thought I'll quickly delve into the medications that are currently licensed in the UK for weight loss. So our first one is Olnistat, which can be available as a PO over-the-counter medication. It's been available for many years now. So it works by inhibiting gastric and pancreatic lipases, so that prevents hydrolysis of dietary triglycerides. So around 30% of fat that's ingested remains unabsorbed and creates a caloric deficit, and that results in gradual sustained weight loss. So it acts locally in the GI tract with minimal systemic absorption, but with it comes the side effects that are common, which include abdominal pain and some people anxiety, but as well as the diarrhea and GI disorders. And some people have described it as having like fatty stools. And this is really important when somebody does ingest a high fat diet, to be mindful that this might happen to them. And I know when it became a P medication, many people tried it, but then they soon came off it because of this particular side effect. And I also thought I'd also list the other rare ones. So please have a look at the BNF profile of Olmistat for further information. The next one is the GLP-1 class of drugs, so semaglutide. Mode of action, it does mimic the GLP-1, activating receptors in the brain and the pancreas, so it reduces appetite via hypothalamic pathways, so it's quite multifactorial. This delays gastric emptying, prolonging fullness, and also enhances glucose-dependent insulin secretion and suppresses glucagon. So in turn, it does result into overall weight loss. Again, remember, semaglutide was first put in the market as a type 2 diabetes medication. There is a recommendation of a stop rule, which means if somebody does not achieve, has anything 5 or over of percent weight loss, of body weight loss after 12 weeks, then potentially this is not something they should be pursuing. When it comes to side effects, there are a bunch of them listed, but they're mostly related to the GI, and many people have started semaglutide. I certainly supported many when it was being used mostly for diabetes some years ago, and they had nausea was a lingering side effect most people had, and that's why when you look at the dosing of it, you start with a low dose of the 0.25. Some people start at milligrams per week, and then you can move on to 0.5 and then 1. And then for weight loss, is actually 2.4 milligrams is what's contained in the Wegovy product that is being marketed for weight loss. So you can imagine if you start with such a low high dose, chances of your experiencing the side effects are higher. So we still recommend a step up dosing approach, so somebody to be able to tolerate it. Again, there's a note in the BNF which I will recommend you have a look, that it must be discontinued if acute pancreatitis occurs. Okay, so and this does present as persistent severe abdominal pain. Okay, and once this is confirmed, treatment has to be stopped and not restarted. So that's really important from a drug safety aspect. Okay. Then next we have liraglutide. Again, activates the GLP-1 receptors in the pancreas, in the gut, and the central nervous system. It enhances glucose-dependent insulin release, suppresses glucagon, slows gastric emptying, and activates satiety centers. Thus, there's a reduced caloric intake, appetite suppression. Again, same for it. Should be discontinued if there isn't more than 5% weight loss achieved in 12 weeks. Side effects mostly listed here as well, and they've put in patients with type 2 diabetes because again, liraglutide was initially marketed for type 2 diabetes, and I thought I would include this here as well for your review, and have a look at the product BNF profile for more details. And next we have tirzepatide, which is a dual GIP and GLP-1 receptor agonist. So it's a long-acting glucose-dependent insulinotropic polypeptide, that's the GIP part, receptor, and the glucagon-like peptide 1 receptor agonist that increases insulin sensitivity and secretion, suppresses glucagon secretion, and slows gastric emptying. So it increases satiety and decreases appetite. So its dual agonism improves metabolic regulation and supports significant weight loss. Again, tirzepatide is the one that's marketed as Mounjaro, with causing resulting in significant weight loss. So side effects, again, one that surprised myself is the alopecia part. So again, one has to be counseled about it. If that does happen, that is a side effect documented as a common side effect of tirzepatide, and the other ones are all GI related as well. It also does cause pancreatitis and gallbladder disorders in a few people. So people have to be mindful and be informed of that. And please have a look at the product monograph in the BNF for further details. So I thought I'll just quickly include here what it's been accepted or restricted. It's restricted use in Scotland, and then it was reviewed in Scotland and for weight management. And it has clearly been stated that for weight loss and weight maintenance, it is an adjunct to a reduced calorie diet and increased physical activity, okay? And the person must have at least a BMI of 30, or if it's or 27, and they must have at least one of these weight-related comorbid conditions, so hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease, prediabetes, or type 2 diabetes. So there's restrictions to its use, and I think it should be the same in the rest of the UK. So have a look at where your health board is to see what restrictions there are. Okay, so I thought I'll put everything here in a snapshot. You all know the three major obesity medications in the UK are all injectables once weekly, which is for semaglutide and tirzepatide. Liraglutide is a daily injection, and Orlistat is an oral capsule. So here's a snapshot with the mechanism of action, which is something important for you to know. But practical considerations for all require diet and physical activity, reinforcement and consistency, access to motivation, counseling, and patient support groups is important, and all of these should be avoided in pregnancy, except Orlistat that could be used. But it does also reduce effect of oral contraceptives. So again, somebody has to be counseled appropriately when they're on it. Okay. So there's some important safety information that has been put through, and I just extracted this from the BNF for you to be aware of. So 2019, the GLP-1 agonists report diabetic ketoacidosis when used with insulin. Okay, and then there's one for Saxenda, liraglutide, vigilance required due to potentially harmful falsified products, 2023. And this has also come through with not just Saxenda, but also Ozempic, Mounjaro, Wegovy, all of them. There is a bunch of falsified products out there. And I think there was a factory busted in Northampton just a few months ago. So just be careful when people bring this product. So just coach people or always counsel them to make sure the product they're using is the authentic one. And then potential side effect warning was put through in October of 2024 due to potential for misuse. Again, remember there's risk versus benefit have to be evaluated for each patient, and safety is really important. And just in January of 2025, tirzepatide, as well as the liraglutide and semaglutide showed there was a potential risk for pulmonary aspiration during general anesthesia or deep sedation. So if somebody is going for surgery, this is something they have to be properly counseled on prior to their surgery day. Okay, so each product will have their own recommendation. So I just thought I would quickly mention the evidence around these medications or drugs that are making the headlines. So just last year now, tirzepatide was compared to semaglutide for the treatment of obesity, and this was the SURMOUNT-5 trial. And they concluded that among patients with obesity but without diabetes, treatment with tirzepatide was superior to treatment with semaglutide with respect to reduction in body weight and waist circumference at 72 weeks. So this is something you'd expect because we already know now that tirzepatide has a dual mechanism of action compared to semaglutide or liraglutide. So I would expect this to be the case because it has sort of a more advanced or an add-on mode of action or add-on effects to the body on a GIP and GLP-1. So theoretically, it would be more effective already. And then there's another trial here. It's called the SHAPE trial, real-world weight loss observed in semaglutide and tirzepatide in patients with overweight or obese with or without type 2 diabetes. This was a SHAPE trial in 2025, and these guys concluded that findings suggest that semaglutide 2.4 milligrams, which is the strength of Wegovy, and tirzepatide, well, that will be the Mounjaro product, are used to descriptively similar when if used in descriptively similar populations, both resulted in clinically meaningful weight loss after 1 year of treatment. So again, they try to compare similar demographics with or without diabetes, and so a high strength semaglutide and regular strength, would say tirzepatide. They don't really mention the strengths in the conclusion here, but they did a head to head, and they say they do almost have similar results, and they both result into meaningful weight loss, which is what we're looking for. Again, I know these two trials made a few people inquire about being switched. For those who are on Wegovy wanting to be switched to Mounjaro, because the news reported it as Mounjaro being better. Because remember, the resources are the same. And I mean, I know many people have opted to go private with these medications, and you might have been involved in dispensing those prescriptions. So when it comes to the landmark trials for these two medications, so the STEP program was the one for semaglutide treatment effect in people with obesity, and that was funded mostly by Novo Nordisk, who are the makers of Wegovy, and then the SURMOUNT series of trials that make tirzepatide. This was funded by Eli Lilly. I just thought I'd mention the market shareholders here. Okay. So there are some challenges with GLP-1 therapies for obesity. So they do help lower blood sugar because originally they were for type 2 diabetes, but they also support weight loss. They also reduce the risk of heart and kidney complications and lower the risk of early death in people with type 2 diabetes. But there's many falsified and substandard medicinal products out there because of the global demand of the GLP-1 therapies. And I think there was a lot, even Hollywood talked about Ozempic and Ozempic use and Ozempic body. And this fueled the spread of falsified and substandard products, threatening patient safety and trust. So ensuring quality requires regulated distribution and prescription by a qualified healthcare provider, strong oversight, patient education, and global cooperation to protect public health. So it's still ongoing now, and there's a lot of falsified products out there just because of the supply versus demand. I know there was a big shortage even when I lived in Canada, where people in the United States were getting scripts from Canada, and that was being shipped through. Then a big supply issue occurred. I think it was the same also over here, maybe just a year ago now, maybe 24, 25, when there was a shortage of Ozempic as a drug before Wegovy was marketed and before Mounjaro came to supply. Okay. So I thought the NICE guideline 246 has a very clear description, and I thought I would include this here. Again, refer to the guideline for a better uh, view of this. But overweight and obesity management, there's the potential care journey of the patient. So there's a diet, there's behavior change support. Medicines are part of it, but not all of it. There's psychological support as well, physical activity. So there's multi It's a multi-approach care when it comes to the treatment and management of obesity. Medicines are just part of it and not all of it. Again, this is the same diagram I thought I'd include here again. Just have a look and have a look at the nice 2, 4, 2, 4, 6, I think. Okay. And then I just thought I would mention too that obesity does affect many, many people worldwide, and it was associated to almost 4 million deaths in 2024. So now GLP-1s have been added to the World Health Organization essential medicines list for managing type 2 diabetes in higher risk group, and with the new guideline, WHO has issued conditional recommendations for using these therapies to support people living with obesity in overcoming this serious health challenge as part of a comprehensive approach that includes healthy diets, regular physical activity, and support from healthcare professionals. So they've added it to the essential uh, medication list. It was initially there for type 2 diabetes, but now they've also added on the obesity part because the number of people projected to be living with obesity will almost double by 2030. So that's quite alarming. So why does it matter? So ourselves as pharmacy professionals, we often are the first contact for weight-related advice, and ourselves as pharmacy technicians and pharmacists, we play a role in identification and brief interventions, medicines optimizations, supporting behavior change, referral to structured weight management services, signposting to support and monitoring medicines used for obesity and other comorbidities. Again, that the safety and the risk and all those side effects that I've mentioned before. Here are some references for you to have a look out with this recording. And again, thank you for listening, and please post any questions on the discussion forum.